Welcome to this deep dive. Today we're plunging into some really fascinating territory, drawing insights from the Huberman Lab podcast all about ketamine.
Mm-hmm.
Our mission, basically, is to cut through the noise, pull out the most important things you need to understand about its clinical benefits, its risks, and, frankly, how this molecule actually works in the brain. Or doesn't.
Yeah, and it's a molecule with quite a history. If you followed this at all, its reputation wasn't always, shall we say, clinical.
Right.
For a long time, it was often mentioned in the same breath as stuff like PCP, phencyclidine. You might know the street names like angel dust or Sherm.
Oh, yeah?
There was definitely lore around it, maybe uncertain truth, but about eliminating pain, maybe links to violence, that kind of thing.
Definitely in that scary street drug category for a lot of people back then. But the transformation is, well, it's pretty remarkable.
It really is.
Now, the conversation about ketamine is almost entirely focused on its potential as a treatment, isn't it? For serious conditions like depression, severe suicidality, PTSD.
And this shift, into widespread clinical use, it's pretty recent, really taken off in just the last, say, 5 to 10 years.
Okay.
But, and this is important, the material makes clear this increased legal access for treatment, it also creates a crossover risk. People can get addicted. It definitely has abuse potential, especially outside a controlled setting.
That's a really critical point to make right up front. Still, despite that risk, the clinical picture is quite compelling for some people. The source material highlights its established uses for major depression, suicidality, PTSD, even calling it potentially miraculous in certain cases.
Miraculous for some is definitely the key phrase there. It's not a magic bullet for everyone.
No.
But for those who haven't found relief elsewhere, maybe with treatment-resistant depression or, crucially, acute suicidality, it can be absolutely life-changing. And we also learned it shows effectiveness for other things, too, like bipolar depression, OCD, anxiety, even substance addiction.
And what's really striking, especially when you think about urgent situations like suicidality, is the speed. The research shows effects can kick in within minutes to hours.
Yeah, it's incredibly fast.
Which is just such a stark contrast to, traditional antidepressants. SSRIs, Wellbutrin, they often take weeks, sometimes months to work, if they work.
Right, and often come with those side effects that can be really tough. Dry mouth, appetite changes, libido issues, sleep problems. Makes them hard or impossible for a lot of folks.
Totally.
And this rapid effect, it also kind of challenges that older idea, the monoamine hypothesis, that depression is purely about lacking serotonin or dopamine or norepinephrine.
Right, the chemical imbalance idea.
Yeah. I mean, while drugs that boost those can help maybe 40% of people, there's actually little evidence for a widespread deficiency of them. Ketamine is clearly working through different, much faster pathways.
But is the relief from a single treatment often quite short, like maybe just 3 days to a week?
That's generally true, yes, for a single administration. That rapid relief can be pretty transient. So to get more durable effects, studies have looked at repeated dosing. One approach discussed is something like treatments twice a week for maybe 3 weeks. That can provide relief during the treatment and offer some durability afterwards, potentially weeks or months of continued relief.
Okay, that makes sense. So given these powerful effects, the million-dollar question is, how is it actually doing this in the brain? The material gets into some fascinating cellular details. We know it's called a dissociative anesthetic.
Yep, historically used in surgery.
Oh.
And the dissociative part, that describes that kind of liminal state people experience feeling separate from your body, like you're dreaming almost. That's often what's aimed for at the lower treatment doses.
And down at the molecular level, what's its main job?
Its core action is as an NMDA receptor blocker, an antagonist. Now, NMDA receptors, they're absolutely fundamental for many kinds of neuroplasticity.
Neuroplasticity, the brain's ability to change and adapt its connections. I remember the material describing NMDA receptors like an AND gate. They need like unusually high or frequent activity, intense learning, mastering a skill to really open up.
Right.
And when they do, they drive big changes. Pulling in new receptors, changing gene expression, building new proteins. The analogy was muscle growth, right? Stress the muscle, it adapts, gets stronger.
That's a great parallel. So here's the initial puzzle. If NMDA is needed for the kind of brain changes that help overcome depression, why does blocking it with ketamine actually help?
Yeah, seems totally back. And they saw this in animal studies too, didn't they? Like that learned helplessness model, rats swimming longer after ketamine, even though it blocked NMDA.
Precisely. That animal data backed up the human observations. The breakthrough insight, as the material explains it, is that ketamine isn't just blocking NMDA everywhere. It seems to preferentially block NMDA receptors located on inhibitory neurons.
Okay. The neurons that act like brakes on other neurons, so
Yeah.
blocking the brakes on the brakes
Got it.
effectively takes the overall brakes off.
You got it. By reducing inhibition, especially on excitatory neurons in mood-related circuits, those excitatory neurons start firing in these powerful, rapid bursts.
Okay.
And these bursting patterns, they're highly effective at driving neuroplasticity, strengthening the very connections needed for a more positive mood. This whole disinhibition thing seems key for the more lasting relief.
And this is where it gets even more interesting because this burst firing seems directly tied to another critical molecule, BDNF.
Yes, brain-derived neurotrophic factor, BDNF. Think of it as a crucial player in learning, memory, brain changes, often called brain fertilizer.
Yeah, I've heard that.
But the source notes is probably more complex, maybe even acts like a neurotransmitter itself. It binds to a receptor called TRKB.
So how does BDNF connect to what ketamine's doing?
Well, that burst firing we just talked about, triggered by ketamine's disinhibition, causes a rapid release of BDNF. This makes those mood circuits highly plastic, really quickly building new connections or strengthening old ones, like inserting new glutamate receptors, growing neuronal branches, that sort of thing.
And there's solid evidence linking BDNF, right? We learned about studies where mice engineered without BDNF don't get the antidepressant effect from ketamine.
Exactly. And humans with a specific variation in their BDNF genes seem to have a reduced response too.
But then there was another twist, wasn't there? Something even more direct.
Yeah, this was quite surprising. According to the research cited, ketamine might not just cause BDNF release indirectly through that bursting. It might also directly trigger BDNF release and get this potentially even mimic BDNF by binding to the TRKB receptor itself.
Wow. So it's not just telling the brain to make its own growth factor. It might be adding some directly or acting like it. That's way more active than just blocking something.
It really suggests the multi-pronged approach, right? Pushing positive neural changes from several angles. And this complexity, it kind of contrasts with other substances mentioned, like psilocybin, where the action seems more straightforward, mainly via serotonin receptors.
Yeah. Okay, so we've got NMDA disinhibition bursting, EDNF-driven plasticity. Feels like a solid pathway. But then the research throws in another layer, the opioid system.
Yes, this was a bit unexpected for many. Turns out ketamine can also interact with receptors in the opioid pathway, the mu and kappa receptors specifically. These are the same receptors our body's natural opioids bind to, affecting pain, mood, consciousness.
And it wasn't just ketamine itself, but also something it gets broken down into, a metabolite.
Right, HNK hydroxynorketamine. And this metabolite, HNK, seems to specifically activate the opioid system.
Which leads to a huge question. Is the antidepressant effect coming mainly from that NMDA plasticity stuff we talked about? Or is it significantly driven by activating the opioid system, maybe via HNK? Or both?
That became the critical question. And the material highlighted a key study, Williams and Shatar, where they gave people ketamine for depression, but also gave them naltrexone.
Naltrexone, that blocks opioid receptors, right? Often used in addiction treatment?
Exactly. And what was so revealing was that when they blocked the opioid receptors with naltrexone, it actually blocked the antidepressant and anti-suicidal effects of ketamine.
Whoa. But did people still feel the immediate effects? The dissociation, the trip?
Yes, that's the kicker. The subjective dissociative experience, the euphoria, that stuff still happened even with the opioid receptors blocked.
That's huge. It suggests the acute trip itself might not be the necessary ingredient for the longer-term antidepressant benefit.
It strongly suggests that, yes, the actual therapeutic effect seems critically tied to activating the opioid system, which appears distinct from the dissociative feeling itself.
That completely reframes how you might think about why it works. It's not just the weird subjective state. It's these specific underlying neurochemical events, more like a wavefront, as the source put it.
Yeah, I like that description. The drug kicks off multiple processes, NMDA, BDNF, plasticity, and opioid system effects, and they likely unfold over different timescales, contributing to immediate, medium, and longer-term changes.
And these molecular changes, they don't just happen randomly. They impact specific brain circuits involved in mood and motivation.
Right, they have to translate to the network level.
Which circuits are we talking about primarily?
Two key ones mentioned were the habenula, sometimes called the disappointment circuit.
Okay.
It's linked to pro-depressive states, tends to lower dopamine, increase cortisol. Interestingly, it's even negatively affected by things like too much light exposure at night.
And the other circuit?
The mesolimbic reward pathway. This involves areas like the VTA, nucleus accumbens, places rich in dopamine neurons. This pathway is all about reward, motivation, generally antidepressive effects.
So how does ketamine influence the interplay between this disappointment circuit and the reward pathway?
It seems to reduce the inhibitory output from the habenula onto the reward pathway. Basically, it weakens the disappointment circuit's ability to clamp down on the reward pathway.
Making the reward pathway more available, more responsive.
Exactly. And not only that, but ketamine also seems to bolster plasticity within the reward pathway itself and strengthen its connections to the frontal cortex.
The frontal cortex, that's our executive control center, right? Strategy, planning, assessing outcomes.
Precisely. It's vital for evaluating effort versus reward, adjusting our behavior based on feedback, navigating life's complexities. Strengthening those connections could make people more sensitive to the positive outcomes of their actions, better able to strategize for goals, relationships, work, you name it.
Which all leads beautifully into a really crucial point the research emphasizes. These drug-induced changes in the brain circuits, they sort of bias the system in a good direction, but they need reinforcement from actual behavior.
Absolutely. Critical point. You cannot separate the neurochemical changes from the behavioral consequences. The drug might open a window, a period of enhanced plasticity, but you have to climb through it.
So if someone gets ketamine treatment but then continues isolating themselves, doesn't work on healthy habits, keeps thinking negatively, they're basically fighting against the potential benefits.
That's exactly right. Those pro-depressive behaviors work against the neural changes the drug is trying to promote. On the flip side, engaging in what the material calls antidepressive behaviors.
Like what?
Things like connecting with people, finding stimulating work or activities, getting those foundational habits right. Morning sunlight, good sleep, exercise, nutrition. These actions bolster and solidify the positive shifts the drug initiates.
It was summed up perfectly in the source. Better living through chemistry still requires better living.
That's the core message, isn't it? The drug provides a neurobiological opportunity, maybe makes change easier for a time, but consistent positive action is what makes the therapeutic gains stick.
Let's just circle back quickly to that subjective state dissociation. You described it as feeling detached, maybe observing yourself.
Yeah.
It's interesting that this state, which ketamine induces, is also sometimes a symptom of PTSD or trauma.
Yeah, it's a strange parallel. The thinking, at least for the sub-anesthetic doses used in treatment, is that this feeling might come from an uncoupling of communication between the higher-level neocortex and deeper subcortical brain areas.
And it even changes brainwave patterns.
It does. Ketamine tends to abolish the normal alpha rhythm you see when you're alert but calm, and instead, it unveils a theta pattern. Theta is more associated with that dreamlike liminal state, right on the border between being awake and asleep.
Understanding that subjective part is pretty important, especially when we get into dosages and how it's delivered, because the variability and risks seem huge.
Absolutely. Huge variability. In a proper clinical setting, the typical dose given by injection IV or IM is around 0.5 milligrams per kilogram of body weight. That's calculated to get that therapeutic dissociative state, not full anesthesia. Very controlled.
But what about other ways people might take it, like orally or under the Tums, sublingually, or even rectally?
Yeah, the material points out those routes have much lower bioavailability, meaning less of the drug actually gets into your system effectively. Only about 25% is active when swallowed, maybe 35% sublingually.
So you need a way higher dose.
A much higher total dose via those routes to get a similar active level in the blood compared to an injection. Like, if someone gets 50 milligrams injected, they might need 150 milligrams orally or maybe 200 milligrams sublingually for a similar effect ballpark.
And that difference is obviously critical when thinking about risks outside a monitored clinic.
Hugely critical. Using it at home or recreationally makes it incredibly hard to predict your response. You don't know the exact dose you're getting active, and there's no immediate help if things go wrong.
The material mentioned the K-hole.
Right. That's basically taking a dose high enough that it pushes you past dissociation into a state that's almost like anesthesia. Pretty unresponsive, potentially unconscious.
And the sources were really clear about the dangers there.
They were. There's a real risk of death, especially if you mix it with other sedatives like barbiturates or alcohol. You can get profound unconsciousness, stop breathing.
Scary stuff.
Plus, The impaired motor function is a massive danger. Trying to drive, even walk around, can be lethal under the influence. It can also trigger seizures because it messes with that balance of excitation and inhibition in the brain. Especially risky if you're already prone to seizures, like from epilepsy or a past head injury.
What about other physical risks?
Well, it's metabolized by the liver, so frequent use, especially oral or sublingual, can elevate liver enzymes. Rectal use apparently bypasses the liver initially, and, as we said right at the start, high potential for abuse, addiction, compulsive use, even when it's causing problems in your life.
Okay, one other point of potential confusion is the different chemical forms, R-ketamine, S-ketamine, or the mix, SR. The source mentioned some conflicting research initially.
Yeah, it can seem complicated, but the material clarified based on the clinical trial data that was available and expert input, according to that clinical evidence for depression treatment.
Yep. The combined SR form seems to be the most potent and effective overall for relieving depression.
Okay, SR is top. What about the pure S or pure R?
The pure S form, which is also called esketamine, seems to be second best clinically. It actually binds more potently to the NMDA receptor, but tends to produce less dissociation at a given therapeutic dose compared to the mixed SR form. That's why esketamine is the one most commonly prescribed clinically now, often as that nasal spray.
Gotcha. And the pure R form.
Pure R, or R-ketamine, appears to be the least potent and least effective. The source mentioned it failed in a clinical trial specifically for depression. Okay. Now, it's always worth saying personal experiences, especially with recreational use, might feel different or highlight other effects, but for clinical depression treatment, that's the hierarchy based on the data presented.
Makes sense. And finally, what about microdosing? There's so much buzz about microdosing different things these days. Does microdosing ketamine show any clinical promise for depression based on this material? The source material was extremely direct on this point, based only on the published clinical studies available when the source was created. There is zero published clinical evidence showing that microdosing ketamine works for depression. Full stop.
Right.
All the positive effects we've discussed in this deep dive come from studies using those higher therapeutic doses, the ones that induce dissociation or are given in controlled, monitored settings.
That's a really important distinction to draw, based purely on the research discussed.
Absolutely. Critical to separate validated clinical findings from anecdotes or practices that just don't have the data behind them yet.
So, stepping back from all this detail, the picture of ketamine that emerges from the material is just incredibly complex, isn't it?
Oh, yeah.
It's not just blocking one thing. It's this really intricate dance involving NMDA receptors on specific neurons, growth factors like BDNF, the opioid system, targeted changes in brain circuits, and then this absolute requirement for active behavioral engagement to make it all stick.
It's truly multifaceted, with effects unfolding over all these different timescales, immediate feelings, medium-term plasticity, longer-term potential changes.
And maybe the most thought-provoking idea to leave people with from this exploration is, well, how does this multi-mechanism action hitting different pathways, different timelines, combined with the absolute necessity of engaging in positive behaviors? How might that reshape how we think about treating complex mental health conditions in the future?
Yeah, it really poses a fundamental question, doesn't it? Could future treatments, maybe for depression, PTSD, similar conditions, could they move beyond searching for that single magic bullet drug? And instead focus more on precisely timed, multifaceted interventions that intentionally combine specific neurochemical shifts with targeted behavioral actions, like a choreographed approach.